excuse me, it's 12:15 and we're going to go ahead and get started again. I'm going to make two brief announcements before I get back into the lecture. I do want to remind you, if you were not aware, that we will be providing you access to the recorded sessions for all 6 days of this course. In order for you to be able to get access to those recorded sessions, but we want to provide it for you up until you take your exam. So we will need you to let us know your testing month. And the way that you can do this is you can, if you're taking this Zoom course, you can email us info@exampro.com once you have your testing month, and we will be able to give you access to the recorded sessions until that time. Second thing I want to mention, so years and years ago, when I first became involved with ExamPro, actually when it was a very small 3-day course and the only presenter was Dr. Shamroth, and I was a candidate like you, the way I found out was word of mouth. Somebody I knew said, "Oh, this is a great little course. It'll really help you for the oral boards. You should do it." Today, you get a lot more of that via social media, not always face-to-face sitting in a room with somebody, but somebody you see something that they liked on social media and it means something to you. So we do ask you, if everybody always, when they have a complaint, they never fail to mention it. But sometimes when people are happy, they're just happy and they don't mention that either. So we do ask you, if you are happy, please, on social media where you can, talk us up, let people know. We believe we're a resource. We're committed to being a resource for helping people prepare for the boards. And we would love for you to let other people know, because that is the main reason still that people get to ExamPro, is from the recommendation of somebody that they trust. All right, I am going to move on and get back into this lecture. When I look at this first slide, there are a couple things that come to mind. First, I think to myself, in a premenopausal patient, in a younger woman, the bone mineral density is mainly dependent upon whether she achieved her peak bone mineral density. Usually occurs by age 40. And in fact, if we talk about the femur, we believe that happens by age 20. So again, for a premenopausal patient, the key factor for bone mineral density is, did she reach her peak bone mineral density? And if she has risk factors or history of medical conditions or problems that might have influenced that, that might give me some concern. For postmenopausal patients, and as we look at this slide and we see the unfortunate progression that osteoporosis unleashes on our physical structure of our bodies, on our bones. For postmenopausal patients, it's related to the rate of bone loss and the duration of bone loss. And as people live longer, we see more of this. And because there are a lot of risk factors for osteoporosis, we'll talk about that in a minute, there are things that can accelerate the normal loss of bone density that, of course, increases around the time of menopause. So let's talk about osteoporosis. ACOG has several publications on this topic, recent in the last couple of years. It is something that, as primary care providers for women, we do all the time. I just want to get my clicker working here. Hold on one second. And let me make sure. Okay, we're good. So we're going to go through several slides on this. This is a very high yield topic. So first of all, osteoporosis. I want you to remember that it is characterized by low bone mass, microarchitectural deterioration in bone, resulting in a loss of quality bone and increased risk of fracture. Okay. We define osteoporosis using a T-score. And a T-score is a comparison of the patient's bone mass to a young, healthy adult. So really the T-score is where it's at. Sometimes we use Z-scores for premenopausal women who have risk factors, okay? But in general, when we talk about osteoporosis, I want you to be thinking about the T-score, okay? We'll talk a little bit more about that in a minute. I mentioned the loss of bone that occurs over a lifetime, and the acceleration that occurs around the time of menopause. So premenopausal bone loss, maybe 0.5% a year on average. Postmenopausal bone loss, we see accelerated up to potentially 5% per year. So again, very, very important that we think about the fact that menopause itself is a major risk factor. So getting back to talk here. Sorry, I had to look down at a notification. When we lose bone due to osteoporosis, it is usually trabecular bone, which is that honeycomb, strong part of the bone. And this is due to increased breakdown of bone, osteoclastic activity, and then as we get older, less bone building, osteoblastic activity. There are many risk factors. So this is just a list of some of the risk factors that you could take into consideration for developing osteoporosis. If you have risk factors and you're under age 65, the question might be, should we do a bone density scan on that patient before age 65, which, as I'll mention in a second, is when we usually start screening? The answer to that question, and I have this on a future slide, is that we should assess the level of risk, and if it reaches a certain threshold, then we would consider screening them earlier. Mention that in just a second. All right, so again, these are risk factors I know that you're all aware of. We've talked about some of the things that are on this list earlier today, like smoking and alcohol. Certainly, again, secondary benefits of quitting, reducing the risk of osteoporosis. So if they ask you in the exam about your patient and your strategies for prevention and screening for osteoporosis, first of all, for prevention, which is really, really important, prevention has to do with minimizing risk factors. It has to do with active exercise, weight-bearing exercise, and having normal, healthy amounts of calcium and vitamin D. And I'll tell you the basic recommendations for daily intake of both of those in a second. And also for preventing fracture, we want to encourage certain behaviors that are, we think of this as fall prevention measures that have to do with basically lowering the risk of somebody falling in such a way that they would break a bone. And I think it's fairly straightforward. We've mentioned several here on this slide, and ACOG mentions these in their publications as well. What about screening? Who should we screen? Without a doubt, I'm expecting to hear you say any patient 65 or older would be screened for osteoporosis. Absolutely, good answer. What about patients that are under 65? I mentioned a second ago, we can look at their risk factors, and if we're concerned, we can calculate a risk. One way to do this is using the FRAX score. There is an online calculator for the FRAX, Fracture Risk Assessment tool, and you put in the information and it gives you their risk for a major osteoporotic fracture. If their risk is above 8.4%, then that would justify doing a DEXA scan before age 65. What is the magic about 8.4%? Why that number? That is the risk for a 65-year-old Caucasian female with no other risk factors besides age and menopause for a fracture. So if a patient exceeds the risk of a 65-year-old, then it would be logical, since we start screening at age 65, that we should screen them. And so I think that's an easy way to remember what is 8.4%. Why is that number significant? That's why. I also want to mention one other thing before I leave this slide. I want to note that a particular risk factor that may come up in the exam, breast cancer patients, if they are being treated with aromatase inhibitors or being treated with chemotherapy, both of those increase the risk of osteoporosis. We do generally recommend a DEXA scan before beginning that treatment, and we repeat that DEXA scan in 2 years. Just one specific scenario that I think is exam relevant. Read between the lines. Okay, let's continue on. Daily intake for calcium based on age. Age on the left, amount of dietary calcium, preferably dietary or dietary plus supplemental. So this is not a supplement you have to take on top of diet. You can do an estimation of dietary intake and then add supplements as necessary to reach this recommended daily allowance. This has not been proven to prevent fractures. The goal of daily allowance of calcium and vitamin D is to have healthy bones, and having healthy bones would potentially, hopefully, reduce the risk of fracture, but it has not been proven per se. Vitamin D, again, does not been proven to reduce the risk of fractures, but for health, it is important. Vitamin D levels, we recommend to maintain a level of approximately 20 nanograms per ml, 600 international units per day up to age 70, 800 international units per day for patients above age 70. So here we get to the T-score. a little bit more detail. When we do the DEXA scan on our patient who's either 65 or under 65 with risk factors, we get the result back. And if the T-score is less than minus 2.5, they have osteoporosis and we would treat them. If the T-score is between -1 and -2.5, we can use the FRAX score in this case to do a secondary evaluation regarding, is treatment justified for this low bone mass result, which does not quite meet the threshold of osteoporosis. And if the FRAX score indicates 20% risk of any fracture or 3% risk of hip fracture or greater than those numbers, then we would treat them. If we have a patient with a history of a fragility fracture, for instance, if she has a greater than 1.5-inch height loss from her peak height at age 20, we can get an X-ray because that's suggestive of fragility fracture. We'll be able to see a vertebral compression fracture. If a patient has a fragility fracture, we would treat them. Before we start therapy, we always want to think about the fact that osteoporosis can be due to secondary causes. And so we usually do a basic laboratory evaluation, which is listed here. I will tell you this exact same list appears in many other places, including ACOG's publication. We're looking for things like low vitamin D levels, hypocalcemia, hyperparathyroidism. There are a number of other conditions that can cause secondary osteoporosis. So again, before we treat somebody, we have a diagnosis. We want to think, should we do any further evaluation? Here's basically a minimum evaluation, and additional testing may be indicated. For instance, if we're trying to rule out other conditions like hyperparathyroidism, et cetera. So I'm going to continue. I'm going to talk now a little bit about management. So there are a lot of different management options, okay? I'm going to specifically focus on bisphosphonates. Bisphosphonates are first line for most postmenopausal women. They are very commonly used. Most of you have experience with them. So there is a somewhat higher threshold you will be held to about knowledge about bisphosphonates. First of all, realize that osteoporosis treatments can be divided into medications that inhibit bone breakdown. Bisphosphonates and most of the medications we use inhibit bone breakdown. They inhibit osteoclast activity. Or you can have medications, and these are usually prescribed by our endocrinology friends for very severe and refractory cases, where the medication increases bone development. It's an osteoblastic type of treatment. So again, for bisphosphonates, they inhibit bone breakdown. They inhibit resorption of bone by osteoclasts. There are a variety of different bisphosphonates that are available. They can be administered orally. They can be administered IV. The bisphosphonates have some potential side effects and risks. And so these are generally rare, but things like the atypical femur fracture, osteonecrosis of the jaw, because of this, we recommend that patients get a drug holiday after 5 years of therapy. ACOG, I believe, has bought into that as well in their materials. So again, these treatments, while they are potentially helpful, they have been shown to reduce the risk of fracture. They are not without their own set of concerns, including potentially the administration, especially with the oral medications. You have to be careful about how this is administered because of the potential for esophageal irritation, and patients who have GI problems may not be the best candidates for this. So the bottom line is that bisphosphonates, which are osteoclastic inhibitors, are a staple, a mainstay of our treatment. When you put a patient on one of these medications, then you will consider reevaluating them, usually no sooner than 2 years. And then if they improve, then you can potentially space that reevaluation out. And I will talk about that in a second. So here is the next slide I have on treatment. I'm going to just cover a few additional treatments that are listed on this slide, but I'm not going to go into as great of detail or emphasize them quite as much. I will just say hormone therapy, which is listed here, is really a preventative. So in a patient who has menopausal symptoms, vasomotor symptoms, who has risk factors for osteoporosis, hormone therapy would be a secondary benefit, not the primary indication, but a secondary benefit for reducing the risk of osteoporotic fractures. Okay. When we talk about treatments, SERMs, an excellent treatment option. I want you to remember this combination as when I think about using raloxifene. It's a patient who has an increased risk of fracture and an increased risk of breast cancer and low risk for VTE and not having vasomotor symptoms. So again, that's quite a combination, but that's the ideal candidate in my mind because again, raloxifene, a SERM, reduces the risk of osteoporosis and the risk of breast cancer, but can be associated with hot flashes and VTE. Many of you are familiar with Prolia. Prolia is a reasonable medication to use. This is a rank ligand inhibitor. However, it is contraindicated in patients with hypocalcemia, and it does have the downside of relatively rapid loss of bone and increased risk of fractures in the first few months after discontinuing therapy. So if you put a patient on Prolia, then you will need to put them on some other anti-resorptive therapy following cessation of that therapy. I just will say about calcitonin, I don't expect you to mention it in the exam. I doubt you are using it. I'm just going to leave it at that. And then for very high-risk patients who need anabolic therapies, bone-building therapies, these patients are generally going to go to our endocrinology colleagues, and the kind of medications that are used for that include PTH hormone and sclerostin inhibitors. And I don't think there is much value to memorizing anything about these anabolic medications other than knowing that they exist and knowing that a patient who's very high risk or refractory could be referred for these type of therapies unless you are using them. And I doubt you are, but if you are, then you obviously have a higher threshold regarding being able to discuss them. Okay, so let's continue on here. So when should you refer a patient to a specialist? I was just mentioning if the T-score is -3 or worse, if they have a new fragility fracture, if they have a normal bone mineral density and a fragility fracture, that's somewhat unusual. Recurrent fractures or loss of bone mineral density while on therapy, those would all be reasons I would consider referring those patients. So what about monitoring patients while they're on treatment? Generally, we would do a DEXA usually every 2 years, but every 1 to 3 years until they're stable. And then we want to think about renal function, vitamin D, and serum calcium. I mentioned these, checking these every 1 to 2 years while patient is on therapy, because these may impact our approach if they are abnormal. If we have the risk factors for referral to a specialist that I already mentioned, we want to take that into consideration and refer as appropriate. All right, the next slide. So this is a relatively classic oral board kind of question. You will be discussing a particular issue. In this case, it's tamoxifen use or raloxifene use. So maybe you're talking about tamoxifen for prophylaxis for breast cancer in a high-risk patient, or maybe you're talking about raloxifene for treatment of osteoporosis in an equally high-risk patient. And they will ask you, tell me about tamoxifen versus raloxifene, or tell me about other SERMs similar, that you may know about similar to raloxifene. And so we'll show you some classic comparisons as we go through these lectures. The ones that we have relatively high suspicion come up again and again in the exam. And this is one of those comparisons. And we've given you in tabular format some of the easy differences and similarities between these two therapies. And obviously they're both SERMs, and they both reduce the risk of breast cancer. There are some differences. The risk of endometrial cancer is one that really jumps out to me. The vasomotor symptoms, of course, are similar between both of them. So take a look at this slide. Don't be surprised with some of these comparisons that we're going to show you. And I think I'll show you one or two more like this as we go through the day. These have been selected out based on our extensive experience with this exam and the feeling that this question is higher yield than average. All right, I'm going to move on. I'm going to talk for a few minutes about obesity. I've been working with ExamPro. This is my 19th year. And this topic has been a topic that was not as important 20 years ago as it is today. And I'm really sorry to say that. We'll talk in a second about the health risks of obesity. They are significant, and they are significant for women, and they're significant for women across the life spectrum, the pattern of the life timeline, forgive me. What I'm going to say first is that you should know, even though there's debate about the use of BMI for defining obesity, it is still the unit of measure for obesity. And so you should be familiar with what is a normal BMI, what is considered overweight, obese, and severe obesity. Generally speaking, the term morbid obesity is discouraged. It's somewhat of a derogatory type of term. And so I always encourage candidates and practicing physicians to eliminate that word and think more about severe obesity, or about just using the BMI. If you know what a BMI is, a BMI of 50 conveys a different message than a BMI of 25. And so, or BMI of 30 for that matter. Okay. The statistics are staggering. You see the bottom of this slide, 9.2% of Americans that are severely obese, 42% additionally that are obese but don't meet the criteria for severe, 32% that are overweight. The majority of our population have a weight problem, and that's unfortunate. I will show you this slide. The CDC has been tracking obesity rates for decades, and the darker the color, the greater the risk of obesity in that geographic area. Back when they first started tracking this in the 1980s, I remember the slides because the slides had some states that were white or had like no color associated with them, because the rate of obesity was less than 10%. And now there's not a single state in the country that is characterized in that way. So why am I spending so much time on this? I'm just telling you, this is a problem that impacts all of us. And by it being a problem that impacts all of us, it is a much more high yield topic to be represented in your cases. And it is also a much more high yield topic to be of interest to your examiners and potentially to come up as a structured case as well. So let's talk about some of the basics. Health risks. This slide shows an easy memory tool. When you're thinking about something that has wide-ranging risks, rather than memorizing all of them, you can simply remember an organ system type of approach. I like this approach for generating broader discussions of risk factors, differential diagnoses, et cetera. And so that's what this slide is laid out like, an organ system approach. And I know you are familiar with many of these risks. I'm going to move forward. When we think about the management of obesity, the most important concept is that moderate improvements, moderate weight loss, decreases health risks. So it's not about an ideal body weight. It's not even about a huge amount of weight loss. If we can get a patient going the right direction, then we reduce their health risks. If you see weight loss of 15%, this can lead to remission of diabetes for some patients. That's a very remarkable accomplishment if they can do it. But usually we focus on smaller amounts, 5 to 10% of initial body weight as the initial goal, which improves life expectancy, improves blood sugar, lowers cholesterol, lowers blood pressure, improves chronic diseases like low back pain, reflux, or obstructive sleep apnea. That's what those abbreviations are. Many patients will be able to reduce the number of medications or potentially lower the dose of medications. And polypharmacy is such a huge complicating factor for many of our patients that anytime we can lower the number or dose of medications, it is always a potential benefit. And this is from a lifestyle change that we can do this. So again, encouraging our patients, we want them to know that the goal is not an ideal body weight, but a modest reduction in weight. 1 to 2 pounds a week is really the maximum that's going to be sustainable. If a patient's losing weight at a much faster rate, it's probably not going to be a long-term sustainable accomplishment. And a reasonable initial timeline is we're talking about looking at this over months, not over days or weeks. And once a patient loses weight, we want to focus on maintenance and then further weight loss if possible. There are 3 components generally in weight loss counseling. First is going to be decreasing calories in the diet, which can also be associated with better nutrition, but they are not exactly the same topic because some very nutritious things like nuts and seeds have a lot of calories. And for weight loss, calories are the key component that we're trying to reduce. Increase physical activity. This is good for two reasons. It may reduce or help maintain reduced weight, although that's a little bit more difficult, but it definitely improves cardiovascular health. And remember, heart disease, number one cause of death in women. And then behavior modification. So we need to modify behaviors that will allow us to maintain and potentially improve on our weight loss. So if you are proposing that you're helping manage a patient's weight loss, here are a couple of things that the examiners might expect to hear from you. They would anticipate you're seeing the patient more than once a year, because once a year is probably not adequate enough unless you've got somebody else co-managing them with you. Seeing the patient about once a month would be a good estimate. You talk to them and refer them for counseling on nutrition and on exercise. Getting them involved in behavioral support groups can be very helpful. Medical treatment is reasonable and appropriate for patients with a BMI greater than 30 or a slightly lower BMI that have medical problems that would expect to improve with weight loss, and surgical intervention similarly for patients with a BMI greater than 40. The dietary changes, also incorporating nutrition, very important, and exercise as a component of long-term behavioral change, very important. So let's talk about bariatric surgery for just a few seconds. First of all, patients who undergo bariatric surgery, particularly the more effective types of bariatric surgery like the Roux-en-Y, are prone to the complication of nutritional deficiencies. Here are here are the recommended vitamins after undergoing that type of procedure, the supplementation that patients should have. If the patient is a preconception patient desiring pregnancy, she should ideally wait 12 to 24 months after her bariatric surgery to conceive. And we should screen her preconceptionally for her nutritional status, looking for deficiencies. When we have a patient who is going to be on contraception following bariatric surgery, LARC methods are preferred. Oral contraceptive pills are contraindicated in patients who had, for instance, a significant malabsorptive procedure like a Roux-en-Y, because it will affect absorption of medications as well as nutritional components. So with that in mind, again, LARC methods are a great choice. So with that said, I'm going to move on. I did not talk about the different type of bariatric procedures that can be performed. I don't think that is a huge focus of the OBGYN board exam because we don't do those procedures. But obviously, there are a group of different procedures, some of them more aggressive than others. I will just remind you that the more aggressive procedures have greater weight loss, but they also are potentially going to have greater complications. I also will mention that there are medications that can be used for weight loss. I think this is particularly important if you prescribe these medications. I don't think it is a tremendously high yield topic otherwise because the medications are problematic and long-term weight maintenance is an issue. Many of the medications that are initially used are appetite suppressants. They have limited duration of use according to the FDA, limited to 12 weeks or less. And all of the medications have pros and cons, just like any medication that we give. So if you are prescribing any of these medications, be prepared to volunteer a little bit more information. I'm going to shift gears and I'm going to talk for a few minutes about intimate partner violence. This is the only slide we have on it, and that is not meant to diminish the importance. It is a very high yield topic. I'm going to quote ACOG, and I'm going to just start with this. Intimate partner violence, what is it? It is a pattern of assaultive and coercive behavior that may include physical injury, psychological abuse, sexual assault, isolation, stalking, deprivation, intimidation, and reproductive coercion. So intimate partner violence is a very broad problem that affects a large number of people across all socioeconomic groups. So really the things I want you to remember about it, we should be routinely screening for it in our practice. I would not be surprised if the examiner asked you how you screen for it. I want you to know that there are a couple of key thoughts to keep in mind as you discuss that. First, we like the screening to be private. This is not something we would ever do in the waiting room. We want to avoid stigmatizing terms like abuse, rape, battered, or violence. We don't want to put words into the equation that inflame the situation. We would like, when we screen, to be able to get accurate information. And it's important to note that self-administered screening tools, where a patient fills out a tool without the physician asking them questions, when done in a private environment, like in the exam room, and computer-administered screening tools, they have been studied and shown to be as effective as physician-directed questioning, okay? So there are a lot of different ways you can do this. It is something we should be doing in our practice. And this is something that we should be doing around the time of pregnancy care, prenatal care as well. So, ideally, not just once, but throughout pregnancy care. The risks with intimate partner violence actually are greatest. The risk, for instance, of homicide is greatest in pregnancy compared to the non-pregnant state. So screening for intimate partner violence, I cannot understate it. And the information in this slide and the additional information I've given you, I think, is where I would focus my brief discussion in the exam. I say brief discussion because, again, they're not going to give you 10 minutes. And so I want you to develop your answer to how do you screen for intimate partner violence, so you could deliver that hopefully in 3 or maybe 4 sentences over 1 to 2 minutes if they give you that much time. All right, let's talk for a few seconds. Multiple slides on this about rape and sexual assault, which could be a component of intimate partner violence. First of all, the definition: penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without that permission of the person. Sexual assault, so that was rape, okay, that relates to penetration. Sexual assault is a broader definition. This is any violence or aggression that encompasses sexual activity as a continuum, including sexual coercion or contact with an individual to abuse or rape them. So rape, sexual assault, it is a big problem, and it is estimated 1 in 5 women over their lifetime, and that is probably an underestimate because it's way underreported. So remember that many of the victims have some acquaintance with their attacker. Also, when we think about screening women, there are a couple of different methods that can be used. And so we have here that, for instance, the SAVE model, and I'm just going to point that out. I'm going to go through these slides relatively quickly. When we think about our initial evaluation, the initial starting point is support and history taking. I encourage you to think about this process as a component of what we call trauma-informed care, acknowledging in your mind and to the patient the effect of the trauma that she's been through, and conducting the support and history taking in the best way we can to resist re-traumatizing the patient, okay? Going on to the rape evaluation. So ideally, it should be done by somebody who is trained to do this. When we talk about SANE, this is a sexual assault nurse examiner. When we talk about SAFE, this is a sexual assault forensic examiner. Patients should be told not to bathe, change clothes, drink, eat, douche, urinate, defecate, wash out their mouth, or clean their fingernails prior to evaluation. It sounds like a terrible thing to have to tell somebody, because I would imagine after being the victim of an assault, all those things would be things I would be thinking I would want to do. But again, for an accurate evaluation, to gather the most information, we need patients to proceed and be evaluated immediately as soon after the event as they can. There are a lot of jurisdictions that have a cutoff of 72 hours after. And obviously by that time, many times there's not much to be gathered from putting a patient through the evaluation per se, although the other components, support, follow-up, potential treatments could still be applicable. So let me move forward. Physical examination, we've just documented for you here the basic physical examination. I'm not going to read this to you. I just want you to be aware of this. I'm going to talk a little bit about laboratory testing. Just to remind you, that the preferred testing, for instance, for trichomonas is nucleic acid amplification testing. This is usually how we're doing our testing today. A lot of times on case lists, we will write culture when we meant a PCR or NAT test. So just think about that thought. If you had written culture on your case list, you can always discuss the test you actually do. That is never a problem, and they will believe you and give you credit. They understand it's a common mistake that we all make. There is some blood testing that we would routinely do, including pregnancy testing, which I think we should never forget, and screening for STDs or STIs. And then if we're not involved in the initial evaluation, we often do get consulted or involved in the treatment, particularly for acute injuries, for prevention of pregnancy, for STI prophylaxis, and then for long-term follow-up and support. So I will just go through a couple of slides I want you to be aware of. First of all, emergency contraception. This slide lists the different options that are available. I'm going to make a few key points I want to emphasize and bring to the forefront of your mind. First of all, combined OCPs are rarely used. They have more side effects, and they're slightly less effective than Plan B, but they might be used in a situation where somebody has limited access to dedicated products for this purpose. So I'll just leave it at that. The levonorgestrel IUD, if you were to give that as a method of emergency contraception, you want to be specific. We're talking about the 52 milligram IUD. It's not an FDA approved indication, but it has been shown to be effective in a non-inferiority study that was done in Planned Parenthood in Utah a couple of years ago. I think it's now 2 years ago. So it is considered an acceptable method of emergency contraception with the benefit of ongoing contraception as well. And so it could be used in these cases if a patient desired it. Of course, the copper IUD that we're all aware of, probably the best choice from a standpoint of highly effective, can be instituted within 5 days and has a long duration of continuation if the patient desires. And then the other medical options that are listed here, I just want to mention that mifepristone for emergency contraception is not available in the United States for this purpose, but just for medical abortion. And of course, we're all aware that's been its own controversy in this past year. So mifepristone, not something we routinely think about, just wanting you to be aware that in some areas outside the United States, it is available for this use. Prophylaxis for STIs. So a couple of points about this slide. First of all, prophylaxis, we're talking about treating somebody without a confirmed diagnosis, okay? When you look at these medications, these are the current doses listed for the particular infections that are mentioned. I want to draw your attention to chlamydia. Remember, the prophylactic treatment is doxycycline, not azithromycin. So in the past, you might have used azithromycin. It is recommended for doxycycline. I want to also draw your attention to HIV. There is no recommendation for routine prophylaxis for HIV. Instead, the recommendation is doing a risk assessment. And then if there is concern for risk for HIV, which I'm sure in many cases there may be, then consider post-exposure prophylaxis. That's PEP, which is different from PrEP, which is pre-exposure prophylaxis. So you might be asked, if you said, you're talking about as a sexual assault case and you talked about STI prophylaxis and they asked you about HIV and you said not routinely, but I would screen for risk and consider post-exposure prophylaxis. You might be asked, what is post-exposure prophylaxis? If you have never given it, it might be a very difficult question. Let me give you an example of how I would answer that question. I would say, well, it's a 28-day course of HAART therapy, started no later than 72 hours after the assault. Now, have I given them the specific medications? No. But have I told them the class, the combination of medications, HAART therapy, that means something? Yes. Have I told them the duration of time in which the therapy would be considered appropriate and effective? Yes. And the duration of time that the therapy would be continued? Yes. So this brings up an important point in the exam. Sometimes you'll be asked something where you don't know all of the details, but you know some of the details. This is how I describe this, work from what you do know to what you don't know. So give an answer that summarizes what you do know. And if they come back with a more specific question, If you know the answer, great. If you don't, you will reach the point in this exam many times, unfortunately, because it's distressing to us. You'll reach the point where you have to say, I don't know, or I would have to look that up. But when you say, I don't know, or I would have to look that up with confidence, when it's an honest answer and it's not the first answer, in any scenario, the first questions are usually easier questions. So when the answer is, I don't know for those, it's always a little more of a problem. But in the discussion of these complicated topics and the broad variety of topics we have in OBGYN, you're going to have to say, I don't know, or I'd have to look it up, or I don't have as much experience with this. I'd have to do some research. It's all the same answer, and it's an okay answer in the exam, given that it is the right answer for you at that point. Okay, so this is another thing you'll get more comfortable with as you practice. Work from what you do know, so get credit for what you do know to what you don't know. All right. I'm going to continue on. This next section, we're going to talk about all of these topics that are listed: infectious diseases, genetic topics, hormone replacement therapy, and a variety of miscellaneous topics. This is from here until the end of the office lectures. So we have 3 office lectures. We're about halfway through the second lecture. By the time we get to the end of the third lecture, we will have covered all of these different topics. The first thing that you have to be comfortable with is that in this exam, there are certain infections that are considered bread and butter, common OBGYN problems. And so the examiners would anticipate that you don't have to look up a medication for a UTI or a PID or BV. Now, you might not know every therapy, but you should have a go-to one that you're kind of familiar with. So with that in mind, we've given you a chart here for some of these common infections, and we've given you the current treatment options, most commonly used accepted treatment options for these different problems. I'm not going to read you the whole chart. I know you guys can read, and I know that you probably know most of this information and probably almost all of it, but I am going to go to the second slide of this because I do want to point something out. So all the information we're presenting you in these didactic sessions, we believe is higher yield than average. That's why we're going over it. And over time, there are certain things that rise to the surface. Looking at this slide, I want to make a very important point that I hope if any of you are searching your email or zoning out, because this is either Zoom or recording, I hope you'll come back to me for just a second, please, because syphilis is a topic not to be ignored. I noticed that some people have none of it and other people have lots of it on their case lists, but syphilis is a public health crisis, if you will. The numbers have been increasing in our country. And so it is something I'm going to take you through in a few minutes. But on this slide, I want to point out one of the questions that I anticipate in today's, in 2023 might come up. And that question would be, what if you can't get penicillin? I mean, we all know penicillin is the preferred treatment for syphilis. In fact, in pregnant patients, it really is the treatment we need to give. So we need to prioritize our stocks of penicillin for pregnant patients and patients who have like tertiary disease, a sequestered site like the eye or the central nervous system, because they need the penicillin for those patients. But what about a non-pregnant patient? And the question is, there's no penicillin available. How would you treat them? Now, I would say that 15 years ago, it might not be as important of a question. But today, we are having penicillin shortages, and it would be a question that is considered high yield and relevant and completely appropriate for them to ask you. So I will just mention to you, although we don't have it on this slide, if you want to write it down, the option that would be most appropriate would be doxycycline. And it would be 100 milligrams PO twice a day, standard dosing. We're all familiar with that. For early syphilis, for the first line on this slide, it would be 14 days. For unknown or late syphilis, it would be 28 days. Okay, doxycycline, that would be the best next appropriate answer for a non-pregnant patient. Again, for pregnant patients, prioritize penicillin. Try to get access to penicillin from a regional center, etc. There are some other agents that could be suggested, but I'm not expecting you have to give a laundry list. Doxycycline is widely known and available, and it would be a good second line choice if penicillin is unavailable for your non-pregnant patient. I've spent enough time on this that if any of you missed this in your exam this year, I'm going to be very disappointed. We want you to do well. That's why we're here. So let's keep going. Okay, I'm going to get back to syphilis as a topic in a few minutes. PID. Empiric treatment of PID is completely appropriate. Why is that? Because we are trying to prevent the long-term sequelae, such as infertility and ectopic pregnancy. Okay, so the only criteria that you need to treat a patient for PID is that she's sexually active and that she has a presentation that could be PID. And in that case, treat her. There are other criteria that increase our concern. I would say that the majority of women with PID will have mucopurulent discharge, a cervical discharge. And if you did a wet prep, the majority of them will have white blood cells on that wet prep. If you are examining a patient who was diagnosed and treated for PID, or who you are presuming has PID and you're thinking about diagnosing and treating her for it, and none of those signs are present, then you have to rethink the diagnosis. But again, the bottom line is that empiric treatment completely appropriate. Why? Because we would rather err on the side of caution and prevent the risks for infertility and ectopic pregnancy. Sorry about that. Okay. What about inpatient versus outpatient management? This is a very straightforward topic, but don't get caught off guard if they ask it to you. This list of things you should be able to easily remember. Bottom line, if a patient is really, really sick and we're not even completely sure whether she needs additional therapy or has a tubovarian abscess or some other condition, maybe a ruptured appy, we're still evaluating her, she's going to stay in-house. If she's failed outpatient therapy, if she has not responded to outpatient therapy, if she will not take outpatient therapy, if she can't tolerate outpatient therapy, if she can't get treated as an outpatient, she has to be an inpatient. Generally speaking, PID is rare in pregnancy, but when it occurs, we do usually treat those patients as inpatients. We don't have to admit patients because of immunocompromised state. If they can take therapy, we can treat them as an outpatient. First episode of PID does not require admission. Nulliparity, not a reason for admission. I promised you I would talk about syphilis. I'm going to spend a few slides talking about syphilis. It is too high yield. We do not want you to get into the exam and not be ready for it. You are familiar with the organism that causes it. You probably are familiar that there is primary, secondary, and latent syphilis. And then in the later stages, tertiary syphilis, which is where we get the most severe manifestations, usually many years later, including neurosyphilis. And neurosyphilis can actually occur at early stages, just more likely in the later time frame. So let's talk about, just for a few seconds, what I want you to remember here. Primary syphilis is from acquisition of infection. The incubation period is 9 to 90 days, and the lesion or the associated finding is a primary chancre. Primary chancre from syphilis is usually a single lesion. It is usually well demarcated. The margins are easy to see. It's like a crater, almost like a punched out lesion. And it is non-tender, not painful. Can occur in the vagina. This means that patients can have a primary chancre and they don't know, and that can be a problem. Secondary syphilis, this is 6 weeks to 6 months after the primary chancre. This is where we get the symptoms like the rash, maculopapular rash. Remember, palms and soles involved with syphilis. Palms and soles, think syphilis. The condyloma dilata. This is those large, raised, gray to white lesions that occur in warm, moist areas, like the perineum, also in the mouth. Okay, so secondary syphilis, that's when these symptoms occur. If the patient is untreated, this will resolve. The patient will improve. She's still infected, but these symptoms will improve. And she'll enter latent syphilis. And there's early latent and late latent. Early latent is defined as up to 1 year from when she became infected. And late latent is a patient who's been infected for more than 12 months. Why does it matter? Well, a couple things. After 1 year, the patient is not infectious by sexual transmission, but she could still transmit syphilis to her fetus. More importantly, in the first year of infection, it is easier to treat the organism, and the patient will only need 1 dose of penicillin, and a patient who's been infected for more than a year will need 3 doses given 1 week apart. Now, one of the classic questions that comes up in the oral board. And again, if you're zoned out, if you're checking your email, come back, please. Classic oral board question. Pregnant patient, new OB labs. She has syphilis. You confirm it. How do you treat her? It depends on whether or not she has any previous testing. If she's completely asymptomatic and has no recollection, she has no chancre, she has no secondary symptoms, she's in latent syphilis. If she's never been tested before, you don't know how long she's had syphilis. So you will have to presume she has latent, and you'll treat her with 3 doses. Very, very important distinction. Now, if she has a chancre, she has secondary symptoms, or she was pregnant recently, had a miscarriage and had her initial testing and she was negative, then you'll know, what's going on. But if she's in late syphilis with no markers for duration, then you have to assume latent, because that is going to be the most appropriate way to treat her. All right, let's go through a couple other high yield, and I'm not focusing on tertiary syphilis. I think that is much less of a concern for you being grilled about in the exam, unless if you personally manage tertiary syphilis on your case list, then all bets are off. Take a closer look. I will say again, IV penicillin, specifically for those patients who have sequestered infection, which it would be like in the eye or in the central nervous system. Testing for syphilis. Here is something that will produce some anxiety for some of you. There are multiple there's mainly 2 approaches to testing for syphilis. And so people get anxious. Which one should I say? You should say the one you do. And if you don't have one that you do, you should pick one that you would do. And that's the one you would discuss. The 2 approaches involve these 2 different types of tests: non-specific tests like the RPR, and specific tests like the FTA antibody test, which look for treponemal specific antibodies. So in the traditional method, which is what I've always done, we start with the RPR. And if the RPR is abnormal, if it's positive, then we do a specific test to confirm that it's due to syphilis. In the other method that's been more commonly adopted by a lot of people, they start with a specific test and then they proceed from there. It doesn't matter which one you do, as long as you realize that there are non-specific and specific tests and how you can use them to confirm or rule out the diagnosis of syphilis. I will also mention that the non-specific tests like the RPR are used in following patients, because the titers go down and they generally go back to negative with time. The specific tests stay positive for life. Very important to realize that. So they're not helpful for following patients in treatment. There are some things that cause false positive RPRs because they're not specific to syphilis. And here's a list of some of those things, including pregnancy can be a cause of a false positive RPR. And so another question in the exam that would be relevant, how would you determine that it's a false positive? And again, this gets into your testing approach and the algorithm that you follow. So just be prepared for that. And then how do you treat syphilis? Again, we're going to treat with penicillin, preferably in pregnancy. That's going to be our choice. We're going to treat it's usually going to be an IM injection, but it could be IV in the severe cases that I talked about, which usually is not the cases that we're treating. But it's going to be penicillin, either 1 or 3 doses. If it's 3 doses, they're separated by a week. Now, we're going to follow them. I want to point out that the goals of treatment by RPR monitoring, what to expect, these are generalizations, okay? Titers decline at varying rates, but in general, if we were to test 3 months after treatment, we would expect a 4-fold decline. If 6 months, we expect an 8-fold decline. Now, these are generalizations, okay? There are some key things to think about. The usual follow-up protocol is to test a patient 6 months and 12 months after treatment. At 6 months, we should see significant improvement, a significant decline in titers. If we see an increase or no decrease, we have to suspect either failure of treatment or reinfection. Anytime there's a 4-fold increase on a follow-up, we know that this patient has something going on, okay? So 6 and 12 months for a patient who doesn't have any significant risk factors would be a reasonable follow-up strategy. I will mention, if the patient as risk factors for reinfection. Multiple sexual partners, works in a sex profession, if you will, where she is having sex for money. Risk factors for reinfection. I would test that patient 3 months after treatment. I wouldn't wait 6 months. If the patient has HIV, I would test that patient earlier and more frequently. So again, the general 6 and 12 months applies to most patients. If a patient had latent syphilis, the treatment takes a little longer to completely affect the disease. And generally, we recommend testing those patients 6, 12, and 24 months, okay? And that's this bottom line here, 6, 12, and 24 months. I would completely agree that that would be for latent. In a patient who's earlier in the disease process, you might stop at 12 months because you see evidence of resolution of disease. And by 12 months, it would not be surprising to see their RPR go back to baseline. Now, anytime you have an STI result that's positive, like syphilis, you should always think about testing for the other common STIs. HIV would be one that commonly can coexist with syphilis because syphilis can break down the barrier to acquisition of HIV. So again, definitely want to think about testing for HIV. And as I mentioned, we follow those patients more closely if they're HIV positive, being treated for syphilis. This is another little point that I do not want you to miss. You'll be given a scenario where a patient, often a pregnant patient, was treated for syphilis. And very soon after, in the first 6 to 8 hours after treatment was initiated, the patient develops symptoms that can sometimes look like an allergic reaction. It's not. It can sometimes be described as onset of preterm labor and changes in the fetal heart rate tracing. But it's not really active. It usually is not active preterm labor. It's not going to progress. It is this Jarisch-Herxheimer reaction. It's an acute febrile reaction that happens as a result of lysis. We believe it happens as a result of lysis of the organisms, releasing endotoxins that are stimulatory to our immune systems and cause this short-term self-limited reaction. The appropriate treatment is going to be supportive care. Obviously, when we talk about fetal management, it's going to depend on gestational age. It's going to depend upon the findings for the fetus. But in most of these cases, this is going to be something where supportive care will lead to resolution of the situation. So the Jarisch-Herxheimer reaction, if you're given this, particularly in a structured case scenario, please don't forget that I told you about this. Okay. Now, a couple of comparison and contrast issues. When we think about syphilis, it is a cause of a vulvar ulcer. The chancre of primary syphilis is a vulvar ulcer. What are some other causes that would be in our mind when we're evaluating a patient? The most common comparison is with chancroid. Chancroid differs from syphilis in several ways. It tends to have multiple lesions. They're painful ulcers. Remember, in syphilis, they're non-painful. The lymph nodes tend to be tender, and in syphilis, they're non-tender. The margins of a lesion in chancroid are often more vague. They're harder to define. Syphilis tend to be relatively clear, punched out margins that are very easy to find, and it's a single lesion, remember, not multiple. So if you put it in summary, syphilis is a fairly straightforward, kind of matter-of-fact, cold kind of presentation. It's not something you'd want, but it's certainly not the hot, pussy, infected mess that you can sort of think of chancroid with multiple lesions, a tender, really sick-looking kind of patient. Not that patients can't be sick with syphilis, but again, talking about the lesions, okay? So I'm going to show you a few slides, diagrams, and pictures to kind of put this in your mind. But before I do that, there are two other things that I want to cover. First, the bottom of this slide. If you are treating a patient for syphilis and you're not, I'm sorry, I got ahead of myself. If you're treating a patient for a vulvar ulcer and you're not really sure what the vulvar ulcer is, one little strategy that can be employed is you can treat them with erythromycin. Erythromycin will cover syphilis, chancroid, granuloma inguinal, and LGV. But unfortunately, it's a much more difficult treatment course, not very well tolerated, longer duration, multiple doses. So it's not an ideal approach, but it is a little bit of gamesmanship. It will cover it would be a correct answer. You could use erythromycin. You might be asked if you suggest it to give a dosing regimen. Depends. There's different dosing regimens that have been suggested. I'm not going to even go that far because I just want you to know that if you were asked, is erythromycin a potential treatment? It certainly could be. Okay, the second thing I want to tell you before we get into these diagrams and picture slides is when we think about a vulvar ulcer, we have to again have a differential diagnosis in mind. I think we more commonly see HSV in a lot of our practices. So HSV would certainly be there, but it doesn't look like syphilis. It's very different if you think about the things I just told you. So HSV, chancroid, LGV, granuloma gonale, Behçet's, vulvar carcinoma. Always be thinking, is vulvar carcinoma a potential increased risk in a given patient with a vulvar ulcer? Also, I will throw out here, although I think it is relatively unlikely because it's rare, you could also have something called a Lipschitz ulcer. This is not an STI, it's relatively rare. It's an immune response to recent infection with other infections like EBV or CMV or Lyme. It's uncertain exactly how it's caused, but again, this can be another potential cause of an ulcer that could occur on the vulva. And anytime you have a positive STI result, so if you test a patient for syphilis, you should test them for a full panel. I mentioned that earlier, second time saying the same thing, just emphasizing the importance. So let's just quickly go through a couple of slides, and I apologize if these are a little bit, if you just ate lunch, they might not be the slides you want to see, but this is important because a picture can be worth 1,000 words. What do we have here? If you look at this slide, the arrow is pointing to an ulcer on the vulva. It is a single lesion, circular, and fairly well demarcated. And this is actually a picture of a primary chancre from syphilis. Here we have a diagram. It shows a lesion in the same position, but the lesion looks different. And I'll go back for a second. Here, pretty well demarcated margins all the way around. Here, you can see there's some breakdown of tissue in the inferior margin of this lesion. This is also showing you a lymph node. This looks like a lymph node that would hurt, although again, that's a very subjective thing, but this is supposed to look like a lymph node that would hurt because this is chancroid. So again, just giving you some images to put this in your mind. This is a picture showing multiple vulvar ulcers. The margins of the one that's on the right side are fairly clear, but then as we look at the others, it's really potentially how many are there. This looks pretty rough. This is actually a picture of chancroid on the vulva. Okay, so remember with syphilis, we're going to have a single lesion. With chancroid, you usually have multiple lesions. What do we have here? Here we have some definite distortion of the anatomy of the vulva. We have on the right side the appearance of some lymph nodes. If you look carefully, you'll notice that these lymph nodes are enlarged in a way where there's a small groove between them, superiorly to inferiorly. That is the groove sign. It is a finding that is associated with LGV. What causes LGV? LGV is caused by chlamydia, specifically the L1, L2, and L3 biovars of chlamydia. All right, going on to this picture. We have here a really distressingly ulcerated vulva. This is granuloma inguinal. Again, this is caused by Klebsiella. Previously, it was classified actually as, I always struggle with saying this one, with Calamidobacterium, okay? The age-old name for this disease was donovanosis. That's an eponym, somebody's name associated with the disease, donovanosis. Again, granuloma inguinal caused by Klebsiella. I'm going to move on. We're going to talk for a few minutes about Bartholin's gland. Bartholin's gland, cyst and abscess, and absolutely bread and butter OBGYN problem. Very, very common that the office case list will have a Bartholin's gland on it. So you can have cysts or abscesses. You can have benign or malignant presentations. A malignancy is relatively rare, Bartholin's gland carcinoma. If you have a very small abscess, less than 3 centimeters, usually IND and sitz baths will be the best choice because these word catheters are hard to place in very small abscesses. And remember, if you're going to use a word catheter, a couple of key points. First of all, you want to make the incision on the vaginal side, preferably at or above near the hymenal ring, so that the Bartholin's catheter can be placed in the vagina, not on the vulvar side, where it's going to be out, irritating, and potentially be pulled out. Okay, you want to make your incision for the word catheter small, a few millimeters, because if you make it a centimeter, the word catheter is more likely to come out. Okay, we want that word catheter to stay, ideally for 2 weeks. So if we make it on the vaginal side and we keep the incision small so it'll stay in place, 2 weeks later, we'll have some reepithelialization of the canal, of the channel that we made, and it will continue to drain, and they hopefully will not get a recurrence. That's the whole purpose of the word catheter. Okay, remember that the word catheter is latex. So for a patient with latex allergy, we would skip that step and we would have to think about marsupialization, where this is done in an OR. Usually we're going to open the cyst and then sew the cyst open so that it heals and continues to drain. And then we also can think about biopsy of the cyst wall, which some people recommend any patient over 40. Other people talk about over 50. The risk factors for Bartholin's gland carcinoma are not clearly established, but anytime that you, oops, sorry, I hit the wrong button there. Anytime that you have a finding that you're concerned about possible malignancy, age, or something about the lesion, then consider a biopsy. And the ultimate treatment would be Bartholin's gland excision. If you have a Bartholin's gland excision on your case list, definitely want to be prepared to talk about that. The big concern with the Bartholin's gland excision is the venous plexus that underlies the Bartholin's gland. The nickname for the Bartholin's gland excision, traditionally in older textbooks, they talk about the bloodiest little surgery in gynecology, because you can get into a catastrophic, significant hemorrhage from those veins that are hard to control. So again, Bartholin's gland excision, you should have some experience and some skill in that if you're doing it. When we talk about Bartholin's gland treatment, if we have an abscess, we do usually culture. Okay, there is increased risk for MRSA. The most common result we're going to get is E. coli. And we would prescribe antibiotics if they have recurrent abscess, extensive cellulitis, pregnant, immunocompromised, risk for MRSA. It's not absolutely required. In most uncomplicated cases, the incision and drainage is the appropriate treatment. But again, if you're going to give antibiotics, Bactrim is a good choice, or you could do Bactrim plus Augmentin or Bactrim plus metronidazole. All right, I'm going to talk for a second about vaginitis. So first thing about vaginitis, self-diagnosis is not recommended. I'm sure all of you get calls from patients and they would just want they want you to call in a treatment for vaginitis, but there are multiple causes of vaginitis and it's really not possible to tell over the phone. So self-diagnosis not recommended. Patients with symptoms, they need clinical evaluation. When you're checking the pH during your exam, if you do that, check from the mid portion of the vaginal sidewall to avoid false positives that could occur from cervical mucus, blood, semen, or lubricants, okay? Remember that estrogen plays a crucial role in determining the normal state of the vagina. During the reproductive years, we have estrogen present. This increases glycogen content in vaginal epithelial cells, which in turn encourages the colonization of the vagina by lactobacilli. And this increased level of colonization leads to lactic acid production and a resulting decrease in the vaginal pH to less than 4.5, which is the normal vaginal pH, less than 4.5. And this acidic environment protects against the growth of pathogenic organisms, and it's key to maintaining that that balanced vaginal microbiome, if you will. And the normal vaginal microbiome is heterogeneous. And the normal ecosystem will include Gardnerella vaginalis, some E. coli, possibly group B strep, mycoplasma, and Candida, commonly found in a healthy, normal vagina, but the balance maintained by that in that estrogen environment and lactobacilli. When we see vaginitis, there are three causes that we commonly are thinking about. right off the bat. Yeast is the first one I'll talk about. So we can diagnose this with microscopy. We can do cultures. We can do PCR-based testing, which many of us are doing. When we check for the pH in a yeast infection, we usually expect to see that the pH would be, again, less than 4.5. With an uncomplicated infection, which would be defined by all four of these criteria here, we treat with intravaginal or oral medication. Oral fluconazole, very commonly used, very effective, single dose therapy, high rate of patient compliance, very few issues or concerns. When we think about complicated yeast infections, we're thinking about any of these other factors, recurrences, severe symptoms. Severe symptoms, if you look at ACOG's practice bulletin 215, they talk about severe vulvovaginal candidiasis with symptoms that include erythema, erosion, fissures, and edema. These patients with severe infections require prolonged topical or oral therapy. When we have a severe case, we have to think about yeast culture because a non-albicans yeast is going to be present 5 to 10% of those cases. It's harder to treat and can be treated with boric acid. Now, I want to bring up a very important point in the exam. If you mention boric acid, which is nothing wrong with vaginal boric acid, do remember to mention that you do discuss with patients the safety issue, that it can be deadly if ingested. So boric acid needs to be stored carefully so that there cannot be inadvertent access by, for instance, children who could be killed if they ingested it orally. So again, this slide talks about the symptoms of severe infection. And with severe infection, we'll use prolonged therapy. For recurrent disease, we'll use prolonged therapy plus suppressive therapy. So prolonged therapy, for instance, with diflucan would be 3 doses over the course of a week, given like on day 3, 4, and 7. And then long-term suppressive therapy would be given once a week for up to 6 months following that. Diflucan is a very safe and easy to use antifungal. There is no liver function testing or monitoring required, even in patients on long-term suppressive therapy. So when we talk about bacterial vaginosis, the second diagnosis I'm going to cover here in vaginitis, remember that it's not a true infectious state, but rather a change in the vaginal microbiome, an imbalance in the species that are present. And most commonly, we think about Gardnerella as being associated, although it's not the only one. The diagnosis of bacterial vaginosis, the classic diagnosis is still Amsel's criteria, having at least 3 of these 4 things. However, that are listed here: pH, amines, the appearance of the discharge, and presence of clue cells. However, there are other tests, and many of us are doing these nucleic acid amplification tests, like the Affirm test. I'm just mentioning it as an example. I'm not recommending it, but again, because there's lots of different approaches to do this, but you should still be familiar with Amsel's criteria in case they ask. We're always going to treat symptomatic patients. Sometimes we'll get a pap smear that will actually show evidence of this. If the patient is symptomatic, we're definitely going to treat them. We're going to be thinking about the fact that BV can be associated with certain problems. It can be associated with pregnancy complications, increased risk of PID. We can have increased risk for a post-procedural infection. So again, if we diagnose a BV pre-hysterectomy, we want to make sure and treat that prior to surgery. And we can treat this with oral or vaginal metronidazole, or we can use clindamycin. There is this age-old recommendation about avoiding alcohol when taking metronidazole. That is not necessary. The CDC treatment guidelines have debunked that issue. And then for recurrent BV, which would be 3 infections in a year, then we would potentially do maintenance therapy with vaginal metronidazole gel. Okay, so that's key thing there. And then trichomonas, the third cause of vaginitis that I'm going to cover. Nucleic acid amplification testing is preferred, recommended for diagnosis. Trichomonads can be seen on wet mount, live or dead, but when we're trying to rule out the diagnosis, we can have a 50% false negative rate with a wet mount. So the nucleic acid amplification test is the preferred method. The pH increases in the presence of a trichomonas infection. About half of infections are asymptomatic, and you can have prolonged carriage of trichomonas in an asymptomatic state. So a patient who has been diagnosed today has not necessarily been recently infected. So keep that in mind. The treatment for trichomonas, metronidazole is the preferred treatment. We do want to retest the patient in 3 months for a test of reinfection. And trichomonas is one of the 3 infections recommended by ACOG for expedited partner therapy. This would be trichomonas, gonorrhea, and chlamydia. It can be associated with other complications that are listed here on the slide, which you guys are familiar with, so I'm not going to read them. And then this last slide talking about vulvar vaginal health and some of the routinely recommended healthy vulvar practices that I know that you are all familiar with, particularly in patients with recurrent issues. Addressing hygiene and healthy vulvar practices would definitely be something, if I hadn't already, I would definitely get to it at that point. Let me just take a check on where we are on time. Okay, so I'm going to cover this and then we will be to our next break time. Tuberculosis. This slide primarily covers a little bit about testing for tuberculosis and some just basic information that you should know about treatment. We are usually not the primary managers of tuberculosis. Tuberculosis, there are a few questions that do come up on the oral board exam. We often have patients who are co-managed because they will be infected with tuberculosis. So we should be thinking about any case where there's cough greater than 2 to 3 weeks, lymphadenopathy, fever, night sweats, and weight loss, that this might be tuberculosis. We should take a history. History is important. We should do a physical examination. We should assess whether they are potentially at risk. And if we're suspicious at all, we would get a chest x-ray, okay? And in evaluating, that's looking for somebody who maybe has active disease, okay? And by the way, I want to mention something about terminology with tuberculosis. So we used to call latent TB versus active TB, but nowadays the terminology has changed. So when you hear TB infection, that is what we used to call latent TB. And when you hear TB disease, that's what we used to call active TB. So when we are suspicious for TB disease, again, we're going to get our chest x-ray, we're going to do further evaluation, sputum samples, culture for TB, AFB stain, nucleic acid amplification testing, all of these possible methods. I think in most of those cases, we're going to get somebody else involved. Do be aware we are probably more exposed to when we screen for somebody with TB infection, what we used to call latent TB. And this can be done with a PPD. We mentioned that in this slide, and the threshold for positive that's usually used, 10 millimeters. It can also be done with the interferon gamma release assays. These are nice blood tests that can be used to establish TB infection. Classic questions, if you shoot a chest x-ray, what are some of the findings associated with TB? Apical cavitation and hilar lymphadenopathy. Another classic test question, if you have an endometrial biopsy, the classic finding with TB, you can have pelvic TB, okay, is the Langerhans giant cells on histology. You can also get Mycobacterium tuberculosis, sometimes to grow on cultures of endometrial biopsies. When we think about treatment, I don't want you to spend a ton of time becoming an expert on TB treatment, but I want you to realize a couple of basic things. First, when isoniazid is given, which is a common component of TB therapy, you have to supplement with vitamin B6 to reduce the risk of neurotoxicity. Second thing is that usually when TB is treated, it is treated in a 2-stage treatment phase. The first stage is intensive therapy, which is multi-drug therapy for 2 months. And then there is a second stage, which is less medication, but continued for a longer period of time, usually somewhere between 2 to 7 months. So the bottom line is TB treatment involves multiple drugs, initially with intensive therapy for 2 months, followed with a continuation phase with fewer medications for 2 to 7 months. And there are little wrinkles, multi-drug resistant TB. Again, that's not really our lane. That's going to be the subspecialist in infectious disease and pulmonology. So I'm not going to spend any more time on this topic. All right, with that said, I'm going to proceed to this slide, and I'm going to just tell you this slide just outlines 4 terms related to medical ethics that you should be familiar with, and I assume you are. We all think about patient autonomy, the patient's right to choose what to be done. Sometimes we try to use that as a defense of why something was done that wouldn't have been the best choice, but be careful in the exam about that. The other terms that are listed here, I just want to mention to you, beneficence. This is about promoting the health and welfare of our patients. Non-malfeasance, it's our first obligation is not to harm somebody in our treatment course. And then when you hear the term justice in the medical ethic ACOG realm, this is talking about equal service, equal access, medical justice. That's really what that's talking about. All right, so with that, we are going to stop and take a break here. Before we break, I'm going to answer any questions. So let me just go and see what questions we have. And I do not see any questions, which makes me happy, because hopefully that means you were listening and you were satisfied with the information that was given. But at this point, let me just see where we stand here.